the expected, the coronavirus effect. I'm very sorry. My apologies to our listeners and viewers. We're in the midst of a podcast and our network went down. So our great technicians have scrambled and we're back up again. So let me reorient us with our two guests who are joining me for this conversation about the research and clinical trial response to the coronavirus crisis here on Long Island. Our two guests are Lilian Mujica-Perote, who is a professor of biomedical engineering and the director of the Laboratory for Computational Neurodiagnostics here at Stony Brook. She's going to tell us about her work in engineering-driven medicine to help us better understand a variety of diseases, but in particular, the COVID-19 disease. And we also have Dr. Ken Kocianski, the Senior Vice President for the Health Sciences and Dean of the Renaissance School of Medicine. Dr. Kocianski will tell us about the clinical trials and research going on both at the Renaissance School and at Stony Brook University Hospital. Once again, Lily and Ken, welcome back. Thank you for your patience. I'm sorry we had that technical challenge. So, Ken, let me start with you here as we resume our conversation. Tell our listeners and viewers a little bit about the clinical trials and the research posture now being taken by Stony Brook Medicine as we confront the COVID-19 pandemic.
Thank you, Michael. First, perhaps a brief discussion of why do clinical trials. Medicine has a rich history. Why don't we just take our solutions off the shelf and apply them to COVID-19? Well, the answer is we have seen nothing like COVID-19 before, and so we don't have a lot of evidence on which to base our clinical decision-making and our therapeutics. Number two, although there are some suggestions that this drug might work or that intervention might work, we just don't know. And if we just start guessing, working on hunches, then we will not be in a position to provide the very best care to our patients. And so clinical trials are the mechanism by which we carefully and robustly study any sort of new diagnostic, any sort of new prognostication, and especially any new therapeutic that might be useful for a patient with COVID-19. And so the clinical trials that are underway in the United States are numerous. And we have the good fortune of having about 8 clinical trials here at Stony Brook University. Several with a drug that you may have heard about, hydroxychloroquine. This is a drug that was made popularized in a broadcast by President Trump when he surmised that it might be effective. So let's test it rigorously. Let's not just play a trump that it might, a hunch that it might work. Let's test it vigorously. So we have 2 trials of hydroxychloroquine in patients here at Stony Brook. One is, can it be used to protect healthcare workers against acquiring the infection? We have a large number of people here at Stony Brook who are on the front lines, people in the intensive care units, people in the emergency departments, who are seeing patients firsthand with potential COVID-19 disease. So can the use of these drugs prevent them from getting infected? Another round is to test out whether it's effective or not in patients with mild or moderate disease, COVID-19. So we're doing those kind of studies presently. There's a big question in COVID-19. Which is worse, the virus causing the problem, or is the inflammation that the virus evokes worse for the patient? On the side of the inflammation, we're testing out a drug that has been used in patients with widespread inflammation. There's a molecule, a cytokine called interleukin-6, which is responsible for a lot of inflammation in patients with rheumatoid arthritis, with ulcerative colitis, with a number of diseases. Can suppressing IL-6 help out patients with moderate or severe COVID-19? On the other side is the virus. Are there drugs that might be available that could treat the viral infection? And there's a drug called remdesivir. This is a drug that was created to attack the Ebola virus. and there are certain similarities. It's a RNA virus, so perhaps that drug might be useful in patients with COVID-19. And so we are part of a large national clinical trial testing out remdesivir for those patients. Now, for 130 years, people have been using plasma or serum. That is, people who are immune to an infection using their serum or their plasma to treat new patients who have that infection. And we have a randomized clinical trial testing out recovered patients, people who have recovered from COVID-19, and we're collecting their plasma. We're collecting their plasma to give to patients with COVID-19. Now, some institutions are just giving it out. They're just, well, I'm sure it probably works, so let's just give it. I don't believe that, and neither do my colleagues here at Stony Brook. We need to study it because giving plasma is not completely benign. There are some side effects. And so we believe that we need to prove that that kind of treatment works. And so we have steadfastly stuck to a clinical trial protocol of plasma in these patients. And perhaps the most innovative clinical trial, if you will, that we're attempting here at Stony Brook, participating in a national clinical trial, you're going to hear about from Dr. Mohica Parodi, an engineering device that will give us insights into when and how and what happens when a healthcare worker comes across that virus.
So, Ken, thank you. We'll turn to Lily in 1 second here. Let me just ask you to frame what you've just said with reference to one other question. Do you have a sense of where clinical research in the United States is relative to, quote unquote, the rest of the world? Are we ahead, behind, in the same place, or is that impossible to tell?
So we are always in touch with the literature, and the literature, because of our digital age, is always coming out. This morning, I was alerted to a paper on hydroxychloroquine and the initial results of a large Veterans Administration study of hydroxychloroquine. The study was negative, although it was not the most robust of study designs. We are studying it prospectively. That was a retrospective study. But to your question, Michael, where are we? Where is the country? Again, just today, I was made aware of a paper published by the scientists at the University of Texas Southwestern, a very fine medical school and hospital. And they reviewed every paper dealing with therapeutic trials for COVID-19. And their conclusions are there are 7 of the most promising drugs that are being tested right now in patients with COVID-19. And we are actually testing 5 of those 7 drugs here at Stony Brook. And so I think that there is a widespread effort to look at clinical trials for new drugs, new diagnostics in COVID-19 disease. We are part of the forefront of those studies. And I remain optimistic that by studying these drugs carefully, we will be able to add to our evidence base for best decisions for our patients with COVID-19.
Thank you, Ken. Dr. Lilian Mohica Parodi, Ken mentioned the important work you're doing in the interface between engineering and medicine on COVID-19. Maybe you could tell us a little bit about that work. I know you have a special relationship, if we can say that, to this disease. So you can tell us how you came to start focusing on COVID-19.
Thank you very much. We're actually really just at the very beginning stages of launching a study in this area. But as often happens, we were sort of positioned ideally to address this particular question because my lab had been working on related questions in personalized medicine for several decades prior. What I'm really most passionate about is the question of whether we can predict clinical trajectories of diseases. And what I mean by clinical trajectories is the progression of a disease. So we all know that there are some diseases that start very insidiously. So in the case of dementia, for example, There are individuals who notice, in their 50s, 60s, that they're having some what they might call senior moments, and then as they get older, those might progress into what eventually might meet diagnostic criteria. And then there are diseases like schizophrenia, or at least one type of schizophrenia, where someone might seem perfectly fine growing up as a child and then have some stressor at 18 and have a psychotic break and very rapidly become very ill very quickly. And what we're interested in here is, in the context of COVID-19, is understanding the clinical trajectory, not just of the disease as a whole, but specifically why different individuals seem to be responding so differently. So I think, one of the most striking features of this particular illness is that there are some individuals who are infected and are completely asymptomatic. They might be transmitting it, but they themselves don't actually show any symptoms. And then there are individuals who feel sick or even quite sick, but don't require hospitalization. And then there are individuals who die. And initially, I think the assumption was that there might be some predisposing risk factors or that age might be the issue. And to a certain degree, that's true, but it really doesn't tell the whole picture. There's quite a bit of individual variability, even among very similar cohorts in terms of how they respond. And so what we are trying to understand is if we can start to look at the behavior of the immune system and its dynamics as a way to predict what the disease course might look like. And so the rationale behind it is that, as Ken mentioned, it's really not as simple as, you become infected and does your immune system recognize it, pick it up, and fight it. So there are some people who might not have a strong enough immune system to respond. But in many cases, it's not lack of an immune response that kills people. It's actually an immune response that is so strong that it goes into overdrive. And that's very similar to other types of diseases as well. Our physiology is fine-tuned in such a way that most of the variables that are of interest actually need to be maintained within very tight boundaries. So for example, if your glucose levels, your blood sugar is too low, you're very sick. If your blood sugar is too high, you're also very sick. Same thing with sodium, same thing with almost every other measure in the body. And so the way the body regulates all of these measures being exactly within the tight requirements of what the body requires is that there are some mechanisms that kind of push a response up, and there are other measures in the body that sort of a mechanism that pushes the response down. And in a healthy autonomic nervous system, in a healthy endocrine system, in a healthy neural system, in a healthy immune system, there's a balance between this push-pull of what is pushing something up and what is pushing something down. Now that leads to a kind of a dynamic in terms of the variables that you measure. So when we're looking at the brain, we're looking at how the brain is responding to different inputs. And we're looking at the dynamics of that brain response as a clue as to how the neural circuits are balanced between those excitatory and inhibitory components. In the case of the autonomic nervous system, it's a very similar situation where you have a circuit and you have to infer the health of the circuit, or if it's not healthy, the dysregulation, and then understanding what exactly mechanistically is wrong with the circuit simply by going by the dynamics. Now, one of the problems with medicine as it currently stands is that most measurements are made in contexts where it's not possible to take a continuous measurement. So for example, if you want to go and see if you have diabetes, or even if you're insulin resistant, you take a bolus of glucose and then you have a blood measurement before, and then 2 hours later you have another blood measurement. But in fact, if you really want to measure something accurately in terms of its dysregulation, if you're really interested in the circuit and how it's behaving, you need to actually look at the dynamics. And in order to see dynamics, in order to see how something is changing over time, you need to take a very particular type of measurement that won't be captured, for example, by taking blood pressure once in a doctor's office, once a year, or even every 6 months, or even once a month. And likewise, taking your blood sugar every now and then. It really needs to be taken continuously. And so there's a whole evolution in terms of engineering-driven medicine towards being able to even capture those variables of interest in a dynamic, continuous way. So there are continuous ambulatory glucometers that measure glucose over long periods of time. And in this case, what we want to do is to be able to look at the immune system over time so we can see how it's changing over time.
So, Lily, this is this. I sense that this has to do with your so-called Oura Ring project. Is that correct?
Yeah. So, in the last 20 years or so, people have gradually moved towards adopting, even in just ordinary consumers, have been looking at wearables. So what's known as the quantified self. So I'm wearing 2 devices right now. This is the Whoop, this is the Oura Ring. And these are actually biosensors. They're picking up on various measurements ranging from heart rate, respiration, movement. This can be used to calculate sleep performance. In the case of the Oura Ring, it's measuring continuously temperature. And what that affords is the ability to then have the data really for the first time to ask how the disease progression is occurring, not on a daily basis or on a weekly basis, but really on a minute-to-minute basis. And so one of the clues that we have that might be predictive of why some people are recovering very quickly from COVID-19 and other people are degenerating very quickly. And also bear in mind that there's a dynamic in which people go through recovery and relapse behavior. So they think they're perfectly fine, and then they have a severe relapse, and then they get better, and then they have another relapse, and so forth. One of the clues may be found actually in, for example, temperature fluctuations or heart rate fluctuations, because what that might be reflecting is actually the immune system balancing sort of an attack retreat type of behavior that in an optimal immune response is balanced, so that the system is able to activate enough to actually fight the infection, but doesn't get into a kind of an overdrive positive feedback loop where it can't turn off and then the system exhausts itself. And so what we're thinking is that the oscillations that we see in the temperature might tell us something about the behavior of the immune system and how with the strategy essentially that it's using in attacking the infection, and whether that strategy tells us something about the trajectory for how people recover.
And Lily, one more question, then I want to turn to both of you on broader questions about the research initiative. You used the phrase personalized medicine for our viewers and listeners. Maybe you could explain what that means and how that frames this work that you're doing, you in your lab are doing with respect to COVID-19 and more broadly in engineering-driven medicine.
When in fact you are dealing with averages, you're dealing with data that is averaged over large groups of people, then you have outcomes that are averaged over large groups of people. When you want to make individual predictions and assessments of how an individual will respond over time, you need to depend much more heavily on that own individual's data sets. So typically what happens is that in medicine, you need very large numbers of subjects in order to have enough data to reach statistical significance, to have results that seem robust. And for that reason, taking one single person's data isn't sufficient to tell you anything really important about how that person will progress over time. But with the approach that I just described, where you're actually measuring the same individual over long periods of time, you're solving that problem by collecting a lot of data on one person and then using that data to then make predictions about how that person will evolve over time. So how are we testing this? In this case, we're taking 250 frontline healthcare providers at Stony Brook Hospital who are in the emergency department and the ICU. And we're making available, again, this Oura Ring. The reason why we're working specifically with this company is because they include temperature, which is, in this case, a very key variable. And these individuals will be wearing this, and then we will be able to sort of track all of these variables over time. And because we also, they've given us access to their electronic medical records, we also have information that is validated, so it's not by self-report, based on their pre-existing conditions. So for example, how is this affected by autoimmune disorders? So if someone has autoimmune disease, does that change the strategy that their immune system uses to fight an infection? And exactly, how is that improving the strategy? Is it worsening it, or is it just is it adaptive to that particular situation? This allows us to objectively, kind of to Ken's point, use the data to really answer these questions rather than going by hunches or what seems like it might be reasonable, but really answering these questions in a much more rigorous way. And then for those individuals who unfortunately do become infected, because we have their electronic medical records, we'll know were they hospitalized, what treatment did they receive, how often did they receive treatment, when were they discharged, and then this will tell us something about the trajectory for how the disease developed, which will allow us then to kind of refine these algorithms and determine if these dynamics of the variables that we're measuring over long periods of time, which might be up to a year, can predict how vulnerable the individual is to becoming infected, and once infected, whether we can predict the individual variability in terms of how they respond. And that approach is personalized medicine.
That's very helpful, Lily. Thank you. Ken, back to you. You've been a leading advocate for quite a while. You've been a leading advocate for so-called bench to bedside research strategies, closing that gap between work going on at the laboratory bench where basic research is going on, and then moving to the clinical arena where patients are being treated by healthcare providers. Tell us about how this particular challenge, closing that gap, is being met in Stony Brook Medicine, and in particular with reference to the COVID-19 pandemic.
Thank you, Michael, and thank you for not mentioning for how long I have been an advocate for bench to bedside, or even bedside to bench to bedside research. And perhaps I can illustrate what's going on in Stony Brook Medicine with an example. A very astute surgical ICU physician of ours, Jerry Rubano, and his colleagues began noticing that one of the engineered devices that we use very frequently in the intensive care unit and really all through the hospital, what's called a pulse oximeter. It measures, theoretically, how much oxygen is in your blood, how much is on your hemoglobin. And it's a very easy device. You put it on your finger, and it measures the amount of the hemoglobin that's saturated with oxygen. But people began to wonder if that's an accurate measure in patients with COVID-19. And Jerry took about 50 consecutive patients in the intensive care unit and actually measured the pulse oximeter readings against the actual gold standard of measuring oxygen in the blood, and found that in a large number of the patients with COVID-19, there was a discrepancy. So that's the bedside part. Now, where's the bench come in? Well, it's important to know how and why and how come that observation was made. Does it give us insights into what's going on in patients with COVID-19? And so now, in collaboration with members of the Department of Chemistry, in the Division of Hematology, and a number of other people all through Stony Brook University, we've launched an effort to try to understand this discrepancy. The discrepancy is important. The warning goes out. don't believe the pulse oximeter all the time. It may give you a false reading. Check the gold standard more frequently so you know exactly how you're treating patients. And in fact, Jerry submitted a paper for publication just last night with this observation. Now, once we're armed with the explanation as to why this happens, this is a property of the virus. Is a viral protein causing this misdiagnosis, this fooling of the pulse oximeter? Once we have that in hand, it may give us great insights into the disease, and it might give us a handle on a better way to diagnose, prognosticate, or treat the disease. So in COVID-19, there are ample such examples of disconnects. Why are the patients with COVID-19 developing blood clots? That has been noticed at Stony Brook. It's been noticed all through the country. Another an article appeared in the popular press just this morning about why are patients with COVID-19 so susceptible to blood clotting. Over the years, we have found a number of genetic and other reasons for people to clot excessively. Patients who are perfectly healthy develop blood clots. So is that information useful in helping us understand what's going on in COVID-19 and, importantly, prevent blood clots? And we've already begun to adopt our standard way of treating patients with COVID-19 with that observation in mind. We're much quicker to anticoagulate patients to prevent them from developing blood clots now than we would otherwise standard patients who are equally sick with other diseases. So clinical observations, research into what is causing those clinical observations, and then acting upon that research to better care for our patients. I gave you just 2 examples, but there's probably another dozen examples that we believe we can sort out by, as Lily says, looking at scads and scads of data, and by using the important combination of clinicians and researchers who are working side by side, as we do here at Stony Brook Medicine.
We have a couple of minutes left, so let me ask both of you. We in this series of podcasts where we focused on the coronavirus pandemic, we've always tried to close in asking our guests to sort of try and be prognosticators as best as possible. I mean, from both of you, from your vantage point, thinking about the research and the clinical, engagement with this disease. What do you see in terms of timeline? What would you like to share with our audience today about what they can anticipate and hope for in the weeks and months ahead? Why don't we start with you, Lily, and then we'll turn it to Ken to close.
I think actually my own perspective is that it would be irresponsible of me to try to anticipate how this will play out simply because we don't have the information. And I think it's actually very, very problematic to raise expectations in any particular direction, but rather from my own perspective, again, I think what is most rational is to anticipate multiple scenarios and to prepare ourselves to mitigate the consequences in all of those scenarios.
Ken?
Thanks, Lily. That is a very important caveat that we always have to keep in mind. Looking at our data at University Hospital day after day after day, I do know, as you've read in the popular press, that the first wave, and the reason I say first wave will become apparent in a moment, but this first wave of this pandemic as it's hit Long Island is on the downslope. At Stony Brook University Hospital, our census of COVID-19 patients is coming down nicely. It's about 20-25% lower than it was 10 days ago. And the number of patients admitted to the hospital every day is lower than the day prior. We're discharging a large number of patients, and we are seeing a large number of patients survive this terrible disease. But we don't know what the future holds because we don't know what fraction of the population in Suffolk County has been exposed to the virus. If 60, 70, 80% of the population has been exposed to COVID-19 and they've developed antibodies and are now immune to the disease, whether they felt bad or not, the future looks pretty good, actually. But if only 5 or 10 or 15%, which is what I think is probably happening, of the citizens, of the residents of Suffolk County has been exposed to this disease and are now immune to it, I think we are going to see wave 2 and wave 3 into the future until and unless we get an effective and safe vaccine that will make everybody immune to this disease. So just as Lily said, we need to prepare for all sorts of scenarios. We need to keep our 6 feet social distancing. We need to keep our masks on. We need to keep washing our hands and making sure that we don't touch our face all the time, because this disease is not going to go away next week or next month. Hopefully in a year, year and a half, when we have vaccines, if we have vaccines, we'll be in a better position to prognosticate that COVID-19 is in our rearview mirror. It's not in our rearview mirror yet.
Well, thank you both for those important insights. I want to thank our guests, Dr. Lilian Mojica-Perotti and Dr. Ken Kocianski. Thank our viewers and listeners for joining us on Beyond the Expected. Be safe, be well. We'll see you and speak with you next time. Thanks so much.